Good afternoon, everyone. This is John Seeger, a pharmacoepidemiologist, and I'm one of the senior faculty at the Decide Methods Center here at the Brigham. And I'd like to share with you today some of my experiences and thoughts regarding propensity score analyses for this educational webinar. This is the 8th in our series of educational webinars through the Decide Methods Center, and I'd also like to point out that there's 2 additional educational webinars that will be coming up. There's one on missing data that will be presented by Jason Roy on the 23rd of June, and there's a webinar on competing risks on the 21st of July by Bob Glenn from the Decide Methods Center. About 2006, I've been teaching a course at the Harvard School of Public Health on propensity score analyses, and I've been updating this slide since then. In 2006, it was a very impressive growth of propensity score analyses in the published literature that we could see, and even since 2006, it's continued to grow, and with the need for comparative effectiveness research that will undoubtedly use propensity score analyses, I expect this will continue even into the future. This growth has been driven by what we all recognize when we do observational research, that is, people who receive treatments really differ from those who do not receive treatments. This differential treatment selection arises because patients are not given treatments at random. They're given treatments specifically to treat a condition, and both explicit and implicit reasons for this treatment selection. We can identify some of those reasons. Explicit ones, the indication for the treatment, the patient's characteristics, their underlying diseases, and even subtypes of the diseases for which the therapy is perhaps most applicable, are explicit things that you might be able to point to as to why a patient received a treatment. In addition, there are judgment that goes into the treatment decision, patient's comorbidities, their history, the experience that the clinician has with that patient. There are also less explicit items that go into the treatment decision, how connected a patient is to the health system, the medicalization of that patient, the past experience of the physician this treatment, and there are regional treatment patterns, things that differ from in different regions of the country, that also influence treatment. Explicit and implicit reasons for treatment selection lead to differences in characteristics of patients who receive one treatment relative to another, and if these characteristics are prognostic of the outcome, then you have confounding. That is, the different therapies for these different characteristics that also influence the outcome, regardless of what effect. Propensity scores allow you to address a lot of different characteristics rather than just individual ones. And let's look at an example here in matching on multiple characteristics. What's nice about matching is it has some very intuitive properties, and it helps us illustrate what we're aiming to do with propensity score matching in the context of cohorts. Here we have an example where a particular set of characteristics, in this case a male who's age 45 and happens to be a smoker with hypertension, you then find an untreated patient who has exactly the same characteristics. The problem is this sort of exact breakdown when you have a lot of characteristics that are typically the case when you have treatments that are prescribed according to patient characteristics. You have a lot of characteristics that differ between treated and untreated patients. So you have age in 10 categories that you want to match on. You have 72 categories, 5 different diagnoses, yes, no for each of them, 5 different prior drug treatments, no for each of them, and then you want to account for cost of care in 5 categories. End up with 102,000 matching groups, and it will be a challenge to find both treated and untreated patients in each of those, or at least a comparison that fills in all these matching groups. And this phenomenon of increasing categories, strata of matching groups, is sometimes referred to as a curse of dimensionality, and the propensity score addresses this, seeing all of the categories into a single value. A frequently used approach is logistic regression, where you develop sort of a clinical prediction rule, each of the three, patient's observed characteristics, and predict each of these observed characteristics. This propensity score, once it's developed, probability of receipt of therapy is used a number of different ways: restriction, stratification, matching, regression adjustment, or weighting, to address the problem of confounding due to differential selection of the propensity score goes back to Rosenbaum and Rubin, and perhaps even earlier, but the first directly published is 1983, and they developed this idea of using this summary variable to adjust for observed variates, and they developed some of the properties of the propensity score in this paper. It's probability that an individual receive his or her treatment given their observed covariates. It's probability, so it ranges between 0 and 1, and it's a one-dimensional summary then of these multi-dimensional variates, and some properties such that when you balance on the score, you also balance on the components of the score. And this is a remarkable thing. That is, there can be dozens or perhaps even hundreds of characteristics that are included in the propensity score. Balance on this one propensity score has the effect of balancing on all of the components. This is subject to certain assumptions about how the propensity score has been modeled, that you have the correct functional form, that you have that the addressing confounding is subject to the assumption of no unmeasured confounding. But here's sort of what a hypothetical distribution of the propensity score might look like. When you develop the propensity score, the people who actually receive the treatment, the initiators in this figure, will have a higher average propensity score than people who receive the propensity or receive the treatment. The shape of the distributions of these propensity scores, and this will allow you to say, who's going to be the treated. You can discriminate the treated subjects from the untreated subjects. But it has this interesting feature, say at a 0.3. If you look at the 0.3 on this figure, that means people with whatever set of characteristics, give them a propensity score of 0.3, they have 30% chance of receiving the treatment based on their observed characteristics. But if you look at the 0.3 on the figure, you see that most of the people at 0.3 did not receive the treatment. Only a small subset of them did. In addition, on the propensity score, you only look at that 0.3, you can't tell who received treatment and who didn't based on the propensity score. You can tell when you see their treatment that they actually received, but the propensity score itself doesn't tell you anymore who received treatment or not. And remember, since the propensity score is this summary of all these characteristics, is all of the characteristics also don't tell you anymore who received the treatment or not. So then it's as if patients receive the treatment at random with condition on the propensity score, provided those assumptions earlier. The amount of discrimination in treated and untreated groups is sometimes measured by a metric, the C statistic. Either characteristics curve, and the intuitive way to think about the C statistic is that if you take from your population at random a treated person and an untreated person, can you distinguish treated from the untreated person based on their characteristics? A statistic of 0.5 means that you cannot tell. That is, the patient's characteristics have no predictive value of treatment, and so that the best you can do is flip a coin. You cannot tell who's going to receive the treatment, who is. If you have a C statistic above 0.5, 7, 0.8, 0.9, that means your ability to discriminate treated from untreated patients is getting higher. The patient characteristics tell you who's going to get treatment and who's not. So there's sort of a metric of discrimination between the treated groups. And I've described because I'm going to mention it a little bit more in some of the diagnostics that can be used in the propensity score. Should always use the propensity score. And there was an interesting study done by Cepeda and colleagues a few years back where they looked at either doing a cohort study using logistic regression, that is outcome, logistic regression, and they simulated a number of different strengths of true association, either an odds ratio of 2, 1.5, or 3, compared to the propensity score, the same sort of associations in the underlying data. And there was more bias with logistic regression than there was with propensity scores when there were more, or when there were fewer than 7 or 8 events per covariate. That is, these are outcome events per covariate that you include in the model. When there are just outcomes and a lot of covariates that you put into the model, with logistic regression, you have a lot more bias than you do with the propensity score. But the propensity score allows you to build a richer model of exposure, your modeling exposure with the propensity score, than you can with outcome, where there are few outcome events. And this is assuming that you have a lot of exposed events. So when common exposure and rare outcome, there's a clear advantage to the propensity score over traditional logistic regression modeling. In the situation reversed, when you have a common outcome, there may be an advantage to using the propensity score. And if the traditional modeling with logistic regression or other types of modeling approaches actually have an advantage over the propensity score. Just a consideration about whether or not the propensity score is an appropriate analytic method. So now to go into a example of some work that I did based on statin use and outcome with acute myocardial infarction. So this is sort of an observational study of statin use and the effect on myocardial infarction. So a situation where you're studying a drug for its intended effect, and so you kind of expect a fair amount of confounding by indication here. Claiming this is a good test case, and the reason is that there's a number of clinical trials that really suggest where the effect should be. That is, I have listed here a number of clinical trials. There are large randomized trials of statins observed across a number of different statins. The study used patients with differing amounts of underlying disease and different levels of LDL, so that the treatment effect of statins was fairly homogeneous. That is, you didn't see a lot of heterogeneity across statins and across different patient populations. And also the example of the CARE trial, that's the cholesterol and recurrent events study. This is people with pre-existing heart disease giving pravastatin or placebo, and pravastatin had a 24% reduction in the risk of, in the case, fatal coronary heart disease or non-fatal myocardial infarction. The thing you can observe from the figures is that the effect of statins is largely through their cholesterol, reducing LDL cholesterol, and that it takes some time for that effect, the reduction in cholesterol, to translate into a reduction in outcomes of coronary heart disease, so that there was a lag. Drivers are essentially on top of one another before they start separating, reflecting the underlying mechanism. I chose to study this in an observational study using HMO, and the data occurred through the 1990s. I got the study as a sort of a new user design, identified statin initiators and comparators, that is, people who are similar to statin initiators but who did not initiate statin within blocks of calendar time. This was to make sure that I had a concurrent comparison group. I expected that the patient characteristics that led to the selection of statin therapy would perhaps found the association. Here's some of the clinical practice guidance. This is the National Cholesterol Education Program's adult treatment guidelines for initiating drug therapy in patients with hypercholesterolemia, and the initiation of drug therapy depends on the underlying risk category, level, and the characteristics that go into this risk consideration are coronary heart disease, age, and then some other patient characteristics. I would expect that statin users would tend to have higher LDL levels, tend to have more diabetes, more smoking, more hypertension, and more underlying coronary heart disease. I identified the statin initiators. I had over 4,000 of them, and then 4,000 concurrently matched non-initiators, but just matched strictly on time, not matched on any characteristics. And what we found was that for example, LDL level, 100 among the statin initiators, 155 among the non-initiators. So LDL is a predictor of statin initiation, and that was borne out in the data. And so then looking at percent versus 5%, so a fairly large difference in the portion of patients with underlying coronary heart disease. Using the propensity score, just looking at the underlying data, those groups, so very adjustment for the occurrence of myocardial infarction, I observed statin initiators had functions more rapidly than non-initiators, a doubling of the risk of myocardial infarction. Statin, that reflection of underlying selection of patients to statin therapy. There's approximately this doubling of the risk of myocardial infarction. For anything, the process of developing the propensity score, about 50 variables that I put into the propensity score, and here's what the distribution of the propensity score looked like. That the statin initiators in the blue line tended to have a higher average propensity score than the non-initiators with the magenta line. Matched on the propensity score, then the two curves fall on top of one another. Important feature, though, of matching is that very lowest, or the very highest propensity score in this case, people who have a propensity score above 0.9 were not matched. You can see now in the matched curves, highest propensity score is around 0.88. doing matching has all of the components of the propensity score. This is my before match table of the characteristics and now after matching table of the characteristics. So we saw before that the LL level was quite a bit different between the two groups, the initiators and non-initiators, is now almost perfectly balanced, 177 in each of them. And the underlying ischemic heart disease is now approximately 15% in each of those groups. The large change to notice from the prior table to this table, in addition to the balance, is the number of statin initiators. Before 4,000 statin, and now I have 2,900. So I've lost about a third of my statin initiators in this propensity score matching approach. But what I've gained by taking out some of these statin initiators is a fairly high degree of balance between the compared groups. And now, I follow these groups for the occurrence of myocardial infarction. I see statin initiators accumulate myocardial infarctions more slowly than the non-initiators. And the relative reduction in myocardial infarction, hazard ratio of 0.69, is actually pretty close to the hazard ratio that was observed in some of the randomized trials of statin initiation. So that's seeing an effect that's very, very much in the ballpark of what was observed in the randomized trial. But more than that, also we see a pattern of the myocardial infarctions where it matches similar to what was observed in say, the CARE trial, where there was a lag from the patient of the statin therapy and the divergence of the survival curves, so that is consistent with the effect of the statins. That is, it working through the lowering LDL levels, and then the effect of low LDL, the beneficial effect of lower LDL on the coronary plaques. If there's been a confounded effect, then you might expect to see the curve diverge almost immediately, where the mechanism for the effect of whatever you're observing is not due to the underlying biology of and pharmacology of the drug. It's due to the fact that one group is at higher risk than the other. So this is actually a very encouraging diagnostic sign here. Thing you can consider is that the coefficient should make sense within the context of what is known or expected about the use of the drug. Here I have this is a propensity score, and somehow it's coming out correctly. But the idea is that if you look at male sex, this is the propensity score predicting statin initiation. They're at a little bit higher risk of getting statins, and that made sense based on what we expected from the characteristics of the statin initiators and non-initiators before we matched, and also the clinical practice guidelines. Another note is that you still need to pay attention to sort of traditional modeling guidelines when you use the propensity score. You can't put, for example, LDL into your propensity score as a single linear term and expect the score to account for it. The relation between LDL and initiation of statin therapy is nonlinear. As you can see in this curve, that higher LDLs translate into much higher odds of receiving a statin. I incorporated LDL as both a linear and quadratic term in my model. The concern is that you didn't include all the right variables. When I developed the propensity score for statin initiation, I used the EP guidelines. I also talked to some experts in the field, but I wasn't sure that I got all of the right variables. So what I did was an empiric search for variables to put into the propensity score, And this is how I did it. It is sort of a non-sophisticated approach, but there are now much more sophisticated sort of data mining approaches where you can identify variables that are associated with statin initiation and incorporate them. Things you might not have expected. And when you do this sort of data mining exercise, you are almost certain to run across variables that you hadn't expected to be associated with statin, the receipt of statin therapy, that might be worth considering for incorporation into your propensity score. The reason for this is, say for example, we observe that vaccines, that receipt of a vaccine might be associated with receipt of statin in therapy. You might say, well, receipt of the vaccine can't really be a confounder of my association. And so why should I include receipt of vaccine as one of my variables in the propensity score? Well, part of the reason for considering it would be that all of these health services utilization variables serve as proxies for things that you actually don't have directly in your data set, especially when you're using a health insurance claims database as this was, where you have very rich data on health care utilization, but maybe less detail with respect to some underlying clinical variables that you would really like to have. The propensity score might be thought of as this multidimensional proxy, and that allows you to address some not directly collected variables. Taking this a step further, there's a publication by Sebastian Schneeweiss and colleagues relating to the use of what's been termed the high-dimensional propensity score, where there's a sort of an automated process for identification of variables that might go into a propensity score, and using this approach would almost certainly lead to the inclusion of things like the vaccine that I had mentioned before, that correspond to these high-dimensional proxies. Of course, there's no guarantee that you have addressed these unmeasured variables, and these have to be addressed from external information. So in case of this study, we had these clinical trials that we could point to and say, this is what the clinical trials say the effect of statin therapy should be, and so what in the observational setting is borne by those clinical trials. Other approaches, you can ask experts to make sure that they corroborate what you've done with the analysis. You can look at the time course of the outcomes. As I mentioned, there's this sort of expected lag in the effect of statins, and that if you see a divergence of the survival curves immediately, when you expect a lag, that's a suggestion that perhaps confounding is still there. You could look at an index outcome. So say, for example, I was looking at the risk of fracture in statins and non-statin users. Then I could calibrate my cohorts on the outcome I do know about, which is myocardial infarction, and then if I see an effect of on myocardial infarction about what I would expect, then I could say, well, for these other outcomes that I don't know about, say fractures or some other outcome, that I believe that confounding is largely addressed, and so therefore I could have more confidence in the result with respect to fractures. Of course, there's nothing like actual data, and so that you could actually do some additional data collection, as allowed by the data source that you're using, to collect data on this unmeasured variable, either through a medical record review or a survey, and then incorporate that information directly into the propensity score or a subgroup analysis of the cohorts, or there's a well-developed method in propensity score calibration that can use that information. And of course, there's always the approach of using sensitivity analysis, that is to look at what degree of unmeasured confounding, that is the strength of association between exposure and this unmeasured confounder, the strength of association between the unmeasured confounder and the outcome, and the prevalence of the unmeasured confounder, put all that information into it's really just a straightforward spreadsheet analysis, or there's some other more advanced methods for using analyses that would then let you know how plausible such an unmeasured confounder would be. All right, into some other uses of the propensity score. Restriction on the propensity score is always a valuable method. Especially when you see you have a distribution like this where there's a range of subjects at the high end of the propensity score where nobody's exposed. Everybody at this high end of the propensity score receives treatment, or everybody at the low end of the propensity score does not receive treatment. Those regions of the propensity score are are ranges where you have one of the comparison but not the other, and so you need to be careful about analyses that include those ranges of the propensity score. Incidentally, when you do matching on the propensity score, as I did in the statin example, those ranges automatically drop out. You don't have to explicitly drop them out. There's just no match in those ranges, and so you drop the high end and you drop out the low end. There's no overlap there. And what you end up including is strictly the middle range of the propensity score, the range where I might think of this as an empirically identified equipoise. That a range where in the data, it's the treatment decisions seem to be going either way. You see patients with the exact same set of characteristics. Some physicians treat them, some physicians don't treat them, and you can then use that treatment heterogeneity to conduct the observational study. Sometimes you'll hear concerns about or have questions about how high should my C statistic be? Should I be concerned if I end up with a C statistic close to 0.5, or if I end up with a C statistic close to 0.9 or to 1.0? There was a survey of published studies done by Till Sturmer and colleagues years back, but is this a nice review from 1997 through 2003, published studies using propensity scores. They reviewed about 170 studies, and about 70 of them actually reported C statistics, and you can see the range of the C statistics that were reported in these studies. Around 0.8 seems to be the common or the sweet spot of propensity score studies, but there were propensity score studies done with where the C statistic was pretty close to 0.5, or ones that were done with C statistics above 0.9. My statin example, the statistic was around 0.92. So high discrimination between statin initiators and non-initiators, and that's sort of expected based on these clinical practice guidelines and the fact that it was within a single HMO, that sort of a staff model HMO. There's an interesting study done where they were looking at what I'm calling this empirically defined equipoise. They developed a propensity score. This is using data from a registry. This is a registry of patients undergoing either endarterectomy, surgery for the carotid vessel, or stenting, carotid artery stent. So CA is arterectomy, CAS is carotid artery stent, and they developed a propensity score from this clinical practice registry. And see, there was a fairly high discrimination, but the C statistic here was 0.78, so pretty much in the range which is common in propensity score analyses. And there's a fairly substantial overlap in these two treatments, except for the very highest of the propensity score. That highest decile, this is a propensity score predicting carotid artery sting, is almost all carotid artery stents. There are characteristics of patients that puts them into that highest decile is almost deterministic of receiving a stent. And so you look at their propensity score in this paper, and it's on the next slide here. You can see that the strongest predictors, these very high odds ratios, correspond to characteristics that put you in basically that top decile of the propensity score. Most of them have to do with what sort of procedure you had done before. So with carotid arteries, you have two, one on each side, and they can end up also restenosing, so that your prior receipt of a stent or a endarterectomy actually very strongly predictive of your next one. And you can see restenosis of a prior endarterectomy. If you have an endarterectomy and it ends up restenosing, you're almost certain you have an odds ratio of almost 13 to get a stent. That is, you already had a surgery on this vessel. It ended up stenosing. They don't go ahead and do another surgery. They say you probably should get the stent. And similarly, if you've had a prior stent, you have an odds ratio of 8 getting another stent. So since you have these two carotid arteries, one on each side, you get a stent on one. That means you're probably a good candidate for getting a stent on the other. That these very clear indications for getting a stent, that the patients have those are not, there isn't equipoise. There's that a propensity score based analysis that ends up in effect dropping out that last decile. It's absolutely true that you would be restricting your population. You will lose some generalizability, but what you are restricting the population to is to the range of the propensity score distribution that reflects this empirically identified equipoise, and this is the most interesting area for the analysis to be done, because that's where, in practice, the selection of treatment actually differs. I want to go on to another example, and this is an example that helps illustrate the value of stratification on the propensity score. This is a study done by Tobias Kurth and colleagues, and this is a study looking at receipt of TPA, plasminogen activator, a thrombolytic drug, for the treatment of stroke. So this is done within a stroke registry in Germany, and he identified over 6,000 people in the stroke registry, 212 of whom received thrombolytic therapy, the TA. So this small subset received TPA. There had been clinical trials of TA in the setting of stroke, and the clinical trials, the randomized clinical trials, suggested there's neither a benefit nor a harm. Relative risk should be approximately 1 for mortality if you have a stroke patient receiving TPA. But observational studies had fairly consistently shown that there's increased risk of mortality if you receive TPA. So Tobias received this stroke registry data and wanted to see about if the observational study could illuminate what the mechanism for this discrepancy in result is. He developed a propensity score with a lot of characteristics that you can see a set of in this table 1. Patients received TPA tended to have more paresis from the stroke, more damage that led to paralysis, some aphasia, so speech difficulties, and higher Rankin scale. So that and the sum of the characteristics, these and more, this is just a part of the table 1, led to a propensity score with a very high level of discrimination. The C statistic here was around 0.92, and you can see from the graph that there's a fairly substantial difference in the distribution of the propensity scores. There's a large difference in discrimination. The clinical characteristics of the patients really do determine who gets TPA and not. And so he did the analysis, though, a number of different ways. First, there's the crude model. If you just take all patients who are treated with TPA and all patients who are not, the odds ratio was around 3 for for mortality. So that threefold risk of mortality. When he did a multivariable outcome model, put as many variables in, modeled them correctly, age and different interactions between variables, he ended up with an odds ratio of close to 2, still suggesting almost a doubling of the risk of mortality with TPA. So this was in conflict with the clinical trials, although it was pretty consistent with some of the other observational studies. When he did a propensity score and then matched on it, he ended up with an odds ratio 1.7, so pretty close to the clinical trial results. And using the propensity score another way, putting it into an outcome model, had a range of effects from odds ratio 1.5 to an odds ratio close to 2, and then weighting on the propensity score, using the propensity score to reweight your population, gave either odds ratio of 1.1, close to what was observed with matching or with the clinical trials, or an odds ratio of 10, very different from the others. And so it mattered what analytic method he used. To investigate this a little bit more, he stratified the results of the propensity score. And that's in this table. And what we see is that, first of all, there's nobody with very low propensity scores, that is a propensity score below the 10th decile or the 10th percentile, received TPA. Everybody at the 10th percentile or lower did not receive TPA. So all of those people drop out of matched analyses, but those people were included in some of the analyses like the modeling, and that includes everybody. The important part is what we have boxed here. These are people who had the lowest range of the propensity score but still received TPA. The small number of them, only 17. And look at the deaths. There were deaths among the 17 patients. So the death percentage, the percent of people who died, was either 40% or 50%, depending on which percentile you're looking at. Whereas in all other strata of the propensity scores above that, the percent of mortality is considerably lower, 8%, 17%, 14%, 9%. And with the untreated, these are the patients who did not receive TPA, the mortality was more comparable. In fact, at these the very lowest stratum, people who have, or actually the highest stratum of the propensity score, the top row of this table, the empirical odds ratio is 0.5, suggesting that TPA in people who have the most clear indications for TPA actually considerably beneficial. That when you give TPA, then for people with a little bit less clear indication, it's sort of beneficial or harmful. You see the 1.2, 2.14, 1.08. But when you TPA to people to whom it's perhaps not most clearly indicated, you see large odds ratios. So that stratification on the propensity score is sort of a natural way to investigate treatment heterogeneity. That's really what we're observing here, that the effect of TA differs in people who have complications, high propensity scores, than it does among people who have low propensity scores, less clear indications for TPA. And he did an additional analysis where he dropped out people with the lowest propensity score, restricted people with a propensity score above 0.05, and that analysis, what could be called trimming, removing people in the tails of the distribution, there was some overlap of the propensity scores, but these still are in the tail. He just took these people, and when you do that, the different analytic techniques that he used, which before had given very divergent results, now give very, very consistent results. And that really is, again, reinforcing this concept that it was treatment heterogeneity which was driving these differences between the analytic results. To run through some conclusions that I've tried to illustrate here today, I mean, the propensity score as an analytic technique can be very useful for addressing confounding, particularly confounding by indication, and other forms of confounding that are associated with treatment with treatment selection. It allows for this rich model of exposure to be developed, advantageous when there are a number of people with the outcome is small relative to the number of exposed persons, and the number of potential confounders is large. It's particularly beneficial for rare treatment effects, such as might be observed in drug safety studies. And to offer a plea to transparency in the use of propensity scores, to not think of them as a black box, but to be very explicit and explore how to be transparent in your selection of the propensity score, whether the propensity score itself is the right method for whatever question you want to answer. So be transparent in your choice of a comparison group. I wanted to sort of remind again that coronary artery stenosis or study where there was coronary artery stenting versus coronary artery endarterectomy, that they took all of the treatment. They included all these patients who had who had in the past received one or the other of these treatments, and that was a very strong predictor of the next treatment. That may be not what your question is. If your question is what is the receipt of treatment, you want to be careful about how you restrict your comparison group. Transparent in building the propensity score, and transparent in using the propensity score. The example from Tobias Kurth really gave think about in when you do the analysis different ways, you can expect different results, and perhaps that different result is comes from the population to which the results should be applied. And it doesn't mean that the analysis is wrong, one or the other. All analyses were correct. It's just that the inference differed because it was applying to different populations. That was the formal part here, and I'd like to entertain questions if anyone has any about the use of the propensity score.
John, it looks like there's a
question. Do we do questions verbally, or do they have to be entered?
We do questions either way. I see one question that's been entered, and I hear somebody talking, so we can do it. We'll take a question by phone if there's one.
Yeah, this is Eric Smith. I'm curious, and maybe this is just a missing data problem or an imputation problem, but rather than external calibration of the propensity score, what if you already know you have substantially more data for some patients? Let's say 10% of your sample have completed a survey. Can you use a propensity score calibration approach for that, or should you use imputation, or how do you take advantage of something like that?
Yeah, first of all, that's a terrific situation to be in, is to have data, at least for some subset of the cohorts that you're looking at. I can give an example of a study that I've done where we were concerned about unmeasured confounding, and we were to pinpoint a few variables that were the hypothesized confounders. We went through a very laborious process of going to the medical records, obtaining that data, just a subset of the cohorts, because we had these enormous cohorts, 40,000 women in one cohort and 20,000 in this other cohort. It would have been impossible to do this medical record abstraction for everybody, so we just did it for the subset and incorporated that into, in fact, a subgroup analysis to address the question about unmeasured confounding. You could probably do something very similar with what you're describing, where you already have the data for the subset. You conduct the main propensity score type analysis without those variables, using everybody, and then in fact a subgroup analysis on that subset. You did raise, though, an interesting point, which would be you could run that with some sort of imputation approach, although that missing the amount of missingness you're describing would put a strain on some of the assumptions that are involved. I would think that a subgroup analysis of where you have the complete data and applying that to your full analysis, maybe full approach. The study that I actually did that as a data collection approach was with the primary was Mona Eng. ENG is the last name if you wanted to find that study, or you can email me and I can send you a copy.
Yeah, I'm familiar with that one, John, and I emailed you about it. So thanks for reminding me of that.
Yep. A question that came in online, it says, what if you are afraid your sample size is too small for propensity analysis? For example, in performing high-dimensional propensity scores using health, would N equals 800 with only 20 outcomes consider propensity methods? Your cohort is 800, and I don't have here is the number of exposed, but if your cohort is 800, that would, well, depend what fraction of those 800 were exposed. That would likely to mean you build a fairly rich propensity score. The high dimensional propensity score may be constrained a little bit, although there's less of an issue with fitting the propensity score than there's for an outcome model. So you consider a propensity score. Perhaps you might want to attempt high dimensional or use just a custom designed propensity score for that. But what comes, the propensity score actually may have a real advantage here. It really depends on the number of exposed people that you have.
I thought about that. Just for that, let's just assume when she's 800, that 400 are exposed. Presumably that would mean that she could include their modeling exposure, 40 variables, or even if you use the 7 or 8 rule, maybe up to variables in her propensity. Of course, she wouldn't do anything like that in an additional model. Is that correct?
Yes, thanks for thinking that through. That's exactly right. You if that's the case, that is, if half of those 800 were exposed and half were unexposed, you could build a much richer model of exposure than you could of outcome. And doing that, you can address a more concerns about confounding through the propensity approach than you could through the outcome model.
John, I have a question.
Yes.
Yes, Dave Smith. In the example you showed with the statins, you developed a propensity of initiating statins at baseline those patients could have over time, and probably some did, of the non-initiators actually start using statins. And that problem probably becomes worse or more acute with time. Any thoughts about, that's not necessarily a propensity score issue per se, but any thoughts about how one guards against that or handles it?
Thanks. That's an interesting point. For sure, the propensity score, at least the way I laid it out, only balances at the start of follow-up, and that the balancing that you achieved at the start of follow-up could degrade and perhaps degrade substantially over time. In the showed, I did the analysis sort of as an intent to treat analysis. Right? Once a person initiated statin therapy, I assumed they were always exposed till the end of follow-up, and similarly, if I had matched an initiator, I assumed they were non-exposed for the remainder of the follow-up. That approach mimicked the intended approach that's actually used in the randomized trials to which I was comparing. So the large statin randomized trials were all analyzed using this intent to treat approach, and so that was appropriate analysis for that. But in practice, you observe certainly changes in therapy, changes in curates over time. How you handle that, right? It's not necessarily a propensity score problem. It's a maybe if your question involves what is effective therapy as actually used, you might need a different analytic approach, either an as-treated analysis, or if you might have a situation of time-dependent confounding where you need to use more causal methods like a marginal structural modeling approach.
Thanks.
Looks like there might be one last question from the audience, John.
Yeah. Okay, I see one. Let's see. Actually, okay, there was a different window to look in. So, do you ever worry about the Brookhart et al. Finding that you should exclude predictors of exposure from propensity score models, or does this concern not come up in practice? This stand on this. The real concern, that is, if include a correlate of exposure is not a confounder, that is something that associated with exposure that is unrelated to outcome, an instrumental variable. In propensity score, you can actually you can harm your estimation, and that there's and a lot of these automated variable selection procedures almost guaranteed to find those sorts of variables. And there, it harms your estimation is that it's necessary to adjust, and you can actually produce bias by doing that. But the practical issue is perhaps more relevant, is that this is it all depends on the strengths of these associations, and that if there, all these things that are instruments tend not to be strong instruments, and so that the amount of that it harms you is perhaps less of a concern than the concern about leaving out a real confounder. So that on balance, the decision might be favoring inclusion of these variables. But it's absolutely right that if you variable that's definitely unrelated to outcome, that's just related to exposure, you're better off excluding it. It's just hard to make that determination, especially when you see that for sure it's associated with exposure. Let's see. I don't have much. The last question I'll try to address very quickly. Then is about multi-collinearity, and for sure, with propensity, there's a lot of multiclinarity. It's typically not considered a problem, not concerned much about estimating the effect of each of the components of the propensity score. It's using the summary, and it's okay. There's a lot of collinearity within the propensity score. So that's the quick answer to that one. Okay, I'm going to have to wrap it up there. Feel free to email me with questions, and we'll look forward to having some of you on for the next discussion about missing data in June. Thank you.
Thanks.
Has disconnected. The call will now end.